All right, so hi everyone. My name is Tina Park. I'm one of the gastroenterologists who subspecializes in advanced endoscopy at Morningside. It's my pleasure giving you a talk on biliary disorders today. I feel like this is a topic that I knew very little about as an intern. And even in my senior years in residency, this topic was difficult to understand. So I hope that this lecture sort of helps clarify some of the disease entities within the biliary tree. And if you have any questions along the way, please feel free to ask. I've been specifically asked to give this talk in Q&A format. So you'll go through a series of 4 review style questions with me, and we'll talk about different biliary disorders together. So question number 1, this is a 40-year-old presents with intermittent postprandial right upper quadrant pain, nausea, vomiting, fever, secondary to acute cholecystitis. The white blood cell count is 12. LFTs and lipase are normal. He undergoes a laparoscopic cholecystectomy, and on post-op day number 2, he has diffuse abdominal pain and fever. His white blood cell count is 16. Total bilirubin is 2, AST 188, ALT 200, alkaline phosphatase 190. HIDA scan shows the following images on the right. What is the next best step in management? Is it A, check a viral hepatitis panel, B, obtain an ultrasound of abdomen, C, obtain MRCP, or D, perform an ERCP? So let's go through this question together. So this patient basically has acute cholecystitis with normal labs initially, and after a cholecystectomy has acute onset of pain, leukocytosis, and LFT elevation. This picture should really prompt me to think about 2 disease entities. One is a dropped stone during surgery into the common bile duct, so cholelithiasis, and 2 is a bile leak. Typically at the surgical site where a cystic duct has been ligated off, there's a leakage into the peritoneum that can cause severe pain and LFT elevations. So how do you distinguish the 2? So imaging will tell you a lot about what's happening. So MRCP will be the most sensitive way to image the common bile duct. It will pick up about 97% of stones in the common bile duct, and it will be diagnostic for cholelithiasis. Versus a HIDA scan will be the most sensitive way to look for a bile leak. In this question, they're trying to show you a positive HIDA scan on the right. There is a radio tracer accumulation in the subhepatic space right here at 30 minutes. And in 60 minutes, this is also tracing down into the right paracolic gutter into the peritoneal space. Bile can be very caustic, so that can cause severe abdominal pain. And this can occur in about 1% after gallbladder surgery, more commonly after a laparoscopic cholecystectomy than an open cholecystectomy. But it tends to occur when the cholecystectomy is difficult or if the gallbladder is very gangrenous or emphysematous. Symptoms can be non-specific in the beginning, especially if the patient has a JP drain already draining the bile out. But in the absence of a JP drain where the bile is just collecting inside the peritoneum, this will present with severe abdominal pain. And if left alone untreated for a long time, this can lead to peritonitis, very severe infections, fever, sepsis, and even abscesses or biloma. So this is one of our medical emergencies that were an urgent ERCP. And here on the right, you have a cholangiogram during the ERCP demonstrating a bile leak. The black line here is actually an ERCP scope going into a duodenum. And from there, you inject contrast into the common bile duct where my mess is. And normally it should contain within the common bile duct. But you see here, there's a contrast sort of leaking in the area of the gallbladder fossa. So this is a positive cholangiogram for a bile leak at a cystic duct stump. Some of the other common sites for bile leaks include right intrahepatic duct or duct of Luschka, or common hepatic duct, which is the upper area of a common bile duct somewhere right here. So how do we treat this? We treat this with ERCP with sphincterotomy and stent placement. This helps because there's a muscle sphincter right here at the tip of the bile duct at the entryway of the duodenum. So by doing a sphincterotomy, cutting this muscle, it increases the flow of bile from the liver into the duodenum. This is the natural pathway of a bile. Bile will always want to flow to the path of least resistance. So by giving it a stent and a sphincterotomy, you are promoting bile flow into the duodenum and away from the peritoneum, from the leakage. Most patients will respond to this nicely. I bring back patients typically in 6 to 8 weeks, do a repeat cholangiogram to ensure that bile leak has resolved. And then at that point, we'll remove the stent. For very few cases where the leak is persistent and not responsive to a bile duct stent, there are a couple of other options. You can exchange to a larger metal stent. And if you're not responding to that as well, very few occasions patients require surgical resection, like a hepatocoagulanostomy. If patient comes to you without sepsis, then this therapy will work alone. If they come to you with pretty severe sepsis from bile leak and liver abscesses or bilomas, then they may also require a washout or external drains to drain those abscesses. Okay, question number 2. This is a 35-year-old female presenting with right upper quadrant pain and nausea, vomiting due to acute cholecystitis. She undergoes a laparoscopic cholecystectomy with a JP drain placement. She has ongoing abdominal pain and her JP drain is draining bilious fluid. ERCP is performed and reveals this cholangiogram on the right. What is the next best step in management? A, place a plastic stent into the CBD. B, place a cover metal stent into the CBD. C, call the surgeon for surgical repair. D, call the surgeon for additional drain placement. So let's go through this together. So this is very similar to question number 1. This patient has a bile leak and has already undergone an ERCP. Unlike the cholangiogram I showed you in question number 1, the contrast is actually staying within the common bile duct. You're not actually seeing leakage into the peritoneum here. If you look closely, you'll see that there's actually surgical clips where the bile duct used to be, and you're not filling any of the intrahepatic ducts above the common bile duct in the liver. This should raise a suspicion for a complete transection of the bile duct. In this case, the leak is actually coming from above, from the liver into the peritoneum. So the typical ERCP where we place a sphincterotomy and a common bile duct stent here is not going to help resolve the bile leak. These patients will require a surgical correction. In short segment transections, you can try to bring the 2 transected bile ducts together with a T-tube and do a primary end-to-end anastomosis. But in long segment transections, this can be very difficult to perform, or it can be complicated by a severe stricture. So in those cases, patients will require a Roux-en-Y hepatocoagulanostomy. Now, this is a patient that you probably have seen on the floors very often. So question number 3 is a 70-year-old man with a history of hypertension who presents with abdominal pain, jaundice, lethargy. He's febrile to 102 degrees. He's tachycardic to 110. He's hypertensive to blood pressure of 87/50. He has an elevated white blood cell count of 25, elevated LFTs with total bilirubin of 4.8, direct bili of 3.6, AST 200, ALT 200, and alkaline phosphatase of 380. Ultrasound of abdomen shows gallstone in the gallbladder and common bile duct size of 12 millimeters. IV fluids and IV antibiotics were started in the ER. What is the next best step in management? Is it A, continue antibiotics and observe, or B, perform an ERCP, C, obtain a CT scan, D, obtain an MRCP, or E, consult surgery for cholecystectomy. Does anyone want to take a stab at an answer? Kind of hard to do setting.
I saw Adrian, you unmuted yourself. I don't know if it was intentional, but
I was going to say ERCP.
Yes, absolutely correct. So this patient has cholangitis, right? This patient has the Charcot's triad, the jaundice, fever, right upper quadrant pain. And not only that, has altered mental status and hypotension, which is a Reynolds pentad. So cholangitis is caused by biliary obstruction, and most commonly that's by a bile duct stone. So that accounts for majority of the causes for cholangitis. Very, very rarely there will be strictures or malignancy or other causes, but predominantly it's a stone disease. On labs, you'll see elevated leukocytosis and LFTs. And in sepsis and septic shock, you'll also find gram-negative bacteremia, most commonly with E. coli, Klebsiella, and Enterobacter. I feel like in reality, by the time ER calls you, the patient already had an ultrasound and a CAT scan, and maybe you're considering an MRCP. But if you had the option of choosing only one of these imaging modalities, I would probably choose MRCP because it is, again, 97% sensitive for detecting common bile duct stones, is the most sensitive and non-invasive way of visualizing the common bile duct. Now, CT and ultrasound can show biliary ductal dilatation, and CT is sensitive for picking up calcium-based gallstones. But most gallstones are not made of calcium, they're made of cholesterol and other mixtures. So you can miss up to 50% of gallstones on CT scans. And ultrasound, while it's really, really, really good at showing gallstones within the gallbladder, it's not so great at looking at the bile duct. So it can often miss a CBD stone. So again, if you have to pick an imaging modality, which is an MRCP for this patient. So why is the answer C, ERCP, and not MRCP? It's because we have clinical guidelines to show us when to perform an ERCP without further imaging. So according to the ASG guidelines, here are strong predictors for choledocholitis. A very strong predictor would be obviously definitely seeing a stone on the ultrasound and the CBD, but also cholangitis or having a bilirubin greater than 4. If you have any one of these strong, very strong predictors, your likelihood of having a choledocholitis is very high, and they actually recommend that you proceed the ERCP. There are strong predictors for choledocholitis. These include dilated common bile duct, at least 6 millimeters in size, and a bilirubin lower than 4 but greater than 1.8. If you have both of these strong predictors, then your likelihood is still high and you can proceed with an ERCP. If you have only one of these or some of these moderate predictors, then you fall under intermediate category. And in that case, they recommend obtaining further imaging, whether it be an MRCP, EUS, or intraoperative cholangiogram. If you have none of these predictors, then your likelihood is very, very low. And if you have high likelihood in case of cholangitis, bilirubins, or definitive imaging showing CBD stones, then you proceed straight to the ERCP.
Sorry, we lost you for a second there, Dr. Park, for about 20 minutes. But yeah, I think it's clear from the chart, but just so you know, in case you said anything or yeah.
Oh, okay. Can you hear me okay now?
Yes.
Okay, perfect. All right. So the management of cholangitis obviously includes antibiotics, but studies have shown that performing an early ERCP, typically within the first 24 to 48 hours of hospitalization, decreases mortality, both in-hospital mortality as well as 30-day mortality. And ERCP is shown to be very effective at stone clearance, especially if the stone size is smaller than 10 millimeters. So those of you not familiar with the ERCP, basically it's a type of an endoscopy where a camera would go into your mouth to enter your stomach and small intestines. We reach the duodenum and reach the major papilla where the bile ducts connected to your duodenum. And then you would inject a bit of contrast into the bile duct. And here on the left is a cholangiogram showing a very dilated bile ducts with two large filling defects. These are two stones in the distal common bile duct. And we have extraction balloon catheters to sort of sweep out any of these stones from the bile duct. And you can see here, there's a gallstone that's being swept. So on video, it looks something like this. This is a patient with cholangitis. She's actually draining quite a bit of pus from the bile duct. We're cannulating the bile duct right now with a sphincter tone and passing a wire through and injecting a bit of contrast. You'll see a cholangiogram on the left side soon. And then after confirming that you're in the bile duct, you're using a cutting wire right here to perform a sphincterotomy to cut the sphincter of Oddi. And this allows a lot of passageway of bile pus and allows the stone to drain as well. So after performing the sphincterotomy, you'll see that we'll exchange the catheter to an extraction balloon. Coming up here pretty soon is an extraction balloon. At the tip of this catheter, there's a balloon that gets inflated inside the bile ducts. On the left, you'll see here this balloon, the white, that's being swept and being pulled down here. And on the right, you'll see that this is going to extract the stone right here. Okay, so ERCP is effective in 94% of cases. When do you consider IR consult for a PTC drain? This is reserved as a second-line therapy for cholangitis. I would consider an IR drain for patients who have failed cannulation, whether it be because of difficult cannulation, altered anatomy, typically in bypass surgery patients, or diverticulum or abnormal anatomy that prevents a standard ERCP, or patients who are simply too unstable to tolerate an ERCP. So in PTC drain, the drain would go in percutaneously through the liver into one of the dilated ducts of intrahepatic ducts, into the common bile duct, into the duodenum, and this will also help decompress the biliary tree to help control the infection. All right, question number 4. The same 70-year-old man with history of hypertension who presents with abdominal pain, jaundice, and lethargy from cholangitis from question number 3. He undergoes an ERCP and 2 stones are removed from the distal CBD. Fever resolves after the ERCP, blood pressure normalizes, tachycardia resolves, his leukocytosis also resolve, LFTs trend down gradually and is near normal. What is the next best step in management? Is it A, continue antibiotics and defer lab chole since he's older, or B, continue antibiotics and recommend a laparoscopic cholecystectomy? So the correct answer here is B, to recommend a laparoscopic cholecystectomy. I think a lot of times we defer surgery in elderly patients, but stone disease have a high recurrence rate, and studies have consistently shown that patients who undergo ERCP with sphincterotomy plus the laparoscopic cholecystectomy have lower recurrence rates and complications down the line. They have reduced risk of cholelithiasis, cholangitis, and gallstone pancreatitis compared to those who have ERCP alone. And that difference is quite significant, 18% versus 40%. And this benefit was shown to be preserved in patients even older than 75 years old, and in patients with history of cancers, CHF, or liver disease. And they actually had no significant difference in post-op morbidity or mortality, like post-op MI, DVT, or P rates. So we should definitely be offering cholecystectomy for patients with gallstone diseases to prevent future attacks. All right, question number 5. This is a 62-year-old female with history of diabetes who presents with right upper quadrant pain, nausea, fever for 2 days. She had similar pain on and off for a few months. She's afebrile, her vital signs are stable. White blood cell count is 12, and LFTs are elevated with total bilirubin of 3, direct bili of 2.2, AST 164, ALT 300, and alkaline phosphatase 294. Lipase is normal at 20. The MRCP shows the following image on the right. What is the next best step in management? Is it A, surgery for cholecystectomy, B, ERCP for cholelithiasis, C, antibiotics and trend LFTs, or D, obtain a HIDA scan? So this can be a little bit tricky, but the key here is interpreting the MRCP images on the right. So the clue here is this big arrow pointing to a giant, pointing to a giant gallstone. You can see that the bile duct is actually normal in caliber, and the stone seems to be outside the common bile duct. That's because it is. It is in the cystic duct within your gallbladder, and it's compressing onto your common bile duct. So there's a name for this condition. This condition is called Moritz syndrome, where the problem lies within the gallbladder, neck of the gallbladder, or the cystic duct. And this is prevalent in about 2.7% cases of gallbladder surgery patients. And this would present exactly the same way as those with cholelithiasis, with abdominal pain, LFT elevation, and upstream dilation of the intrahepatic ducts. Unfortunately, during the ERCP, you will see like partial filling defect from the extrinsic compression, but you won't be able to remove the stone because the stone is not within your common bile duct. So for these patients, they need surgery. In very severe extrinsic compressions or a large stone disease, some people undergo subtotal cholecystectomy. But most patients are able to get away with a lap chole to remove the impacted stone. All right, question number 6. This is a 44-year-old from Hong Kong who presents with postprandial right upper quadrant pain and chills for 3 days. He reports having similar symptoms intermittently for the past 2 years. He's febrile to 101. His blood pressure is stable. He's a little bit tachycardic with a heart rate of 110s. He's alert and oriented ×3. He appears jaundiced. He's tender in the right upper quadrant without any rebound or guarding. He has a leukocytosis and very high LFTs, total bilirubin of 8, AST 68, ALT 174, and alkaline phosphatase of 600. You get an MRCP, and this shows a diffuse intra and extrahepatic ductal dilatation with numerous stones in the ducts and an arrowhead sign. What is the most likely diagnosis? Is it A, primary biliary cirrhosis, B, primary sclerosing cholangitis, C, recurrent pyogenic cholangitis, or D, viral hepatitis? Okay, so the clinical picture here is basically cholangitis that tends to be recurring. So as the name sort of suggests, this patient has recurrent pyogenic cholangitis. This used to be known as oriental cholangitis and was subsequently renamed appropriately to recurrent pyogenic cholangitis. The exact etiology of this condition is unknown, but it's theorized by many that this starts with a parasitic infection in the past that sort of causes biliary stagnation that leads to inflammatory changes and eventually to infections down the line. This condition is more prevalent in the rural areas of Southeast Asia than in the West. It's characterized by having innumerable pigmented stones in the intra and extrahepatic ducts, and it causes intermittent episodes of acute cholangitis, again, because of the biliary stasis, and that causes transient protobacteremia. Over time, when you have recurrent cholangitis, this can lead to strictures and abscesses. MRCP will show you here a very dilated right hepatic duct, left hepatic duct, very wide and dilated common bile duct here. And all these black dots that you're seeing here are stones. They're innumerable stones in the bile ducts. On the right is an ERCP cholangiogram, again showing a very dilated, wide common bile duct and dilated intrahepatic ducts. And as you can see here, distally, it's tapering off, and this is called the arrowhead sign. So this is a keyword on board exam that tells you that this patient likely has recurrent pyogenic cholangitis. The treatment for this is ERCP to help control the infection and to try to clear the stones. Many of the patients have large stones sort of hiding away in the upper intrahepatic ducts. So they may require lithotripsy during the ERCP for complete stone clearance. And some people may even need multiple sessions of ERCPs for complete stone clearance. The overall recurrence rate for this is pretty high, about 30% recurrence for recurrent stones and cholangitis. And apparently, unfortunately, URSO does not really prevent infections. And in severe cases where it's difficult to clear the stones completely, or the segment of the liver is difficult to get to, they need partial hepatectomy to get rid of the affected segments of the liver. So choice A, PBC is incorrect. PBC is an autoimmune condition. These patients present without symptoms. If they do, they have very mild pruritus. They tend to have isolated alkaline phosphatase elevations and sometimes very mild elevations in bilirubins. They tend to also co-present with existing autoimmune conditions in 20% of the cases. PSC, as you know, is a stricturing disease. They present with either dominant stricture or multifocal strictures of the bile ducts. And that creates a beaded appearance of the biliary tree. That's another keyword in board exams. There's a strong association with ulcerative colitis. About 75% of patients with PSC also have UC. And on histology, because this creates fibrosis, this periductal fibrosis creates an appearance of onion skin. So that's another keyword you'll see for PSC. And viral hepatitis obviously would not present with recurrent attacks of cholangitis. It's an acute infection, and you would expect more predominant elevations in AST, ALT instead of alkaline phosphatase or bilirubin. Okay, question number 7. This is a 50-year-old woman who presents with 1 year of intermittent epigastric pain and bloating. She denies fever, chills, nausea, vomiting, dysphagia, melena, and weight loss. CBC, LFTs, amylase, and lipase are normal. Endoscopy was negative. Ultrasound of abdomen shows a non-shadowing, non-hyperechoic 7-millimeter lesion adherent to the gallbladder wall. There's no pericholecystic fluid, gallbladder wall thickening, or dilated bile ducts. Which of the following is the most likely diagnosis for the ultrasound finding? Is it A, adenoma, B, adenomyomatosis, C, cholesterol polyp, or D, gallstone? Does anybody know the answer?
So Victor in the chat said C.
That is absolutely correct, Victor. All right. So this patient basically has functional dyspepsia and has a gallbladder polyp on the ultrasound. Gallbladder polyps are most often incidentally found when you obtain the imaging for other indications. Unlike a gallstone, polyps are non-mobile. They're not shadowing on the ultrasound. So left here, it's sort of hypoechoic, stuck onto the wall of the gallbladder. On the right here is an imaging of a gallstone. Stones are bright, they're hyperechoic, and they'll oftentimes cause shadowing like this. So this person has a gallbladder polyp and not a stone. Most polyps are benign polyps. About 83% of polyps are benign. The other ones are adenomas or malignant. Of the benign polyps, 80% of them are cholesterol polyps. And some of the other benign entities also include inflammatory polyps, hyperplastic polyps, and adenomyomatosis. Now, they've looked through various risk factors for malignancy, including older age, having symptoms, ALT elevations, or having concurrent stones. And of these, having a polyp size greater than 10 millimeter was found to have the highest risk of malignancy. And because of this, we recommend cholecystectomy for gallbladder polyp size larger than 10 millimeters. The exception to this rule is PSC. PSC patients have a higher risk of cholangiocarcinoma. So for PSC patients, any small polyps, even smaller than 10 millimeters, they would undergo surgery. For non-PSC patients with smaller polyps, we recommend obtaining an ultrasound every 6 months, at least.
Dr. Park?
Oh, can you see me?
Yes, we can see you and now we can hear you. We lost you for a bit and now the presentation is not sharing.
Can you hear me?
Yes.
Okay. Sorry about that.
That's okay.
I think it's Wi-Fi issue.
Yes. Now we can see it. Thank you so much.
Okay. Great. So the polyp size less than 10 millimeters, we recommend an ultrasound for surveillance every 6 months for at least 2 years to show stability. And during the surveillance, if the polyp size grows to be larger than 10 millimeters, you recommend cholecystectomy. And if the polyp is rapidly enlarging, at least 2 millimeters or larger at a time, that's a bad sign. So you'd also recommend cholecystectomy. Now, adenomas, just like polyps, are non-shadowing and not mobile in ultrasound. But as mentioned before, cholesterol polyps are the most common types. Adenomas are rare. Adenomyomatosis is a condition where the muscle layer of the gallbladder wall is thickened. This can be diffuse thickening or localized thickening, making it look like a polypoid or polyp appearance. Its association with cholangiocarcinoma is kind of unknown and unclear, but most people would agree that for gallbladder wall thickening thicker than 10 millimeters to undergo cholecystectomy. And lastly, as we discussed before, gallstones are hyperechoic and shadowing on ultrasound, so it will be an incorrect answer choice for this one. Okay, question number 8. Which of the following factors increases the risk of developing black pigmented gallstones? Is it A, obesity, B, rapid weight loss, C, sickle cell anemia, D, high vitamin C intake, or E, estrogen replacement therapy? This might be an easy question for you guys, but the answer is C, sickle cell anemia. So black pigmented stones are associated with hemolytic conditions. All the other risk factors shown here are associated with cholesterol stones. The exception is the vitamin C. That's actually shown to be a protective factor. So the most common type of gallstones is cholesterol stones. This accounts for about 75% of gallstones. It's more common in Western countries and is associated with obesity, female gender, older age, and family history. Black pigmented stones accounts for about 20% of gallstones. This is made of calcium. It's more common in Asia, and it's more common in patients with cirrhosis or with hemolytic conditions. Brown pigmented stones account for about 5% of gallstones. These are a bunch of mixtures of calcium, cholesterol, mucin, and bacteria, and it's associated with infections and sepsis. In in population studies, here are the risk factors for gallstones: older age, older than 40, female gender, certain ethnicity, having a BMI greater than 32, family history, estrogen, oral contraceptives, certain medications, cirrhosis, decreased physical activity, and rapid weight loss have all shown to increase your risk of gallstones. In rapid weight loss or fasting state, your gallbladder is contracted, so the bile is not flowing as fast as it normally should. And you also try to mobilize more cholesterol from adipose tissue. So your cholesterol concentration in bile increases, so that increases your risk of having a cholesterol stones. And here are some of the protective factors found in population studies. High vitamin C intake, coffee, exercise, high vegetable diet, and statins. All right, question number 9. I believe this is our last question. 68-year-old man presents with 2 weeks of diffuse pruritus, fatigue, and clay colored stools. His wife noticed that his skin and eyes are turning yellow about 5 days ago. Denies fever, abdominal pain, nausea, vomiting. His primary care doctor sends labs, which are notable for very high bilirubin of 20, direct bili of 16, AST 120, ALT 200, alkaline phosphatase 450. Lipase is normal. The patient was sent to the ER. CT abdomen and pelvis shows the following image on the right. Which one of these is most likely diagnosis? Is it A, cholelithiasis, B, cholangitis, C, cholangiocarcinoma, or D, hepatitis A? So on the right, you are seeing a bile duct here, very dilated intrahepatic ducts above here, and there's a cutoff at the confluence. And it doesn't look quite like a round stone. Stone disease, such as cholangitis or cholelithiasis, typically presents with pain plus the LFT elevation. So it's not A or B. This is trying to show you that this person has a stricture, malignant stricture, or cholangiocarcinoma. So anatomically, cholangiocarcinoma can be classified into intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and a perihilar cholangiocarcinoma. Of these types, the perihilar type is the most common type, and this is also sometimes called as a Claskin tumor. Claskin tumors can be further subclassified into bismuth type. So in bismuth type 1, the tumor is at the confluence, but not reaching the confluence. And then bismuth type 2, the tumor is at the hilum, reaching the confluence of the right and left hepatic duct. In bismuth type 3A, you involve the confluence as well as the right hepatic duct. In type 3B, it involves the confluence plus the left hepatic duct. And in type 4, it involves the confluence plus both hepatic ducts. Now, these present typically with painless jaundice, pruritus, clay colored stools, dark urine. Very rarely abdominal pain, weight loss will be late presenting symptoms, and fever is also very rare. The risk factors for cholangiocarcinomas include having PSC, liver fluke infections, congenital disorders like Kuroda's disease or choledochal cyst. In Japanese studies, hepatitis B, chronic hep B, has shown to increase your risk of cholangiocarcinoma, as well as hep C. Alcohol and smoking have had inconsistent study results, but some theorize that that will increase your risk, and obesity will also increase your risk. On exam, you'll find jaundice, kind of rarely hepatomegaly or papilloma mass. On labs, you'll notice very, very high LFTs, typically bilirubin in the 30s or 20s, and elevated C99. Now, this is not a diagnostic test, but oftentimes in cholangiocarcinoma, it will be elevated, typically in the thousands. This tends to metastasize towards the liver, peritoneum, and the lung. And the way we diagnose is either with EUS and or with ERCP. So for those of you not familiar with EUS, it's basically an endoscopy. The scope has a camera at the tip, but it also has an ultrasound probe. So when we go into the stomach or small intestines, we can view your liver, pancreas, bile ducts, and surrounding structures like lymph nodes. So on the right is a typical EUS image of a mass right here, and we can put a biopsy FNA needle through to get a small piece of tissue for pathology. Now during ERCP, we can cannulate the bile duct. Here you see a common bile duct and an intrahepatic duct, but this segment is not filling very well because of a stricture. So we can take a brushing from this for cytology for diagnosis, and ERCP can be also therapeutic because we can place the stent across the stricture to help drain the bile ducts. Now with cholangioscopy, there's even a smaller camera catheter that we can insert into the bile duct to visualize the inside directly. So on the right are some of the cholangioscopy images that we see here. Normally bile ducts are smooth and sort of white, but here you see this big mass growing in the bile duct, and we can use our small biopsy forceps for pathology. So whenever possible, we want to offer surgery for curative resection for intrahepatic cholangiocarcinomas that will involve a partial hepatectomy. For distal cholangiocarcinomas, that may be a Whipple. For hilar carcinomas, they may involve a Roux-en-Y hepaticojejunostomy. Unfortunately, the prognosis for this is pretty poor. 5-year survival rate for resectable disease is about 40 to 50%. And for those who are non-resectable, they would undergo palliative chemotherapy or ablative radiotherapy. And the median survival rate for those patients can be short as 6 months. So that actually concludes my presentation. Please let me know if you have any questions about any of the questions that we reviewed together.
Thank you so much, Dr. Park, and thank you for the interactive cases. We really appreciate the format. So anyone, if you have any questions right now, we do have some time for it. So feel free to unmute yourselves right now, or you can write it in the chat as well. Okay.
Dr. Park, thank you for the lecture. I'd like to ask a question for everybody. Could you comment on the timing of ERCP in patients who have both cholangitis as well as gallstone pancreatitis?
Sure. So I think the question is timing of ERCP for patients with gallstone pancreatitis and cholangitis. Is that correct? So in patients with just gallstone pancreatitis, the ERCP is not urgent. We actually kind of prefer to calm down the inflammation from the pancreatitis with IV fluids and then perform the ERCP a little bit later on. But I'm sorry, go ahead.
No, I was just saying that, yeah, that's
okay. For patients with right, so patients with cholangitis, when they're actually infected because the stone is obstructing the bile ducts and they have fevers, hemodynamic instabilities, or altered mental status, that trumps the pancreatitis. That would become a medical emergency. So we would try to perform an ERCP earlier on within the first 24 hours, ideally, of the presentation.
Thank you.
Thank you so much, Dr. Park. So if there are no more questions, we can take a 10-minute break and then we'll be back at 2 p.m. for our next lecture. Again, thank you so much, Dr. Park. And just for everyone, this lecture will be recorded and uploaded to our webpage as well for future reference.